Welcome back, everyone. This is part 3 of our 5-part series on the acute hospital for conditions of participation from CMS. And as you've had the opportunity to listen to the first 2, what we're doing is we're going through the entire manual, and that is Appendix A, and that's what governs hospitals. Today's program is on nursing and pharmacy. I'm covering a vast number of topics today, so bear with us and we'll go ahead and get started. Well, I want to talk just briefly, before we really do a more of a deep dive here, I want to talk about some changes that really affect nursing, and it's not just nursing. Again, a whole host of items that happen in a hospital affect nursing. Well, let's go ahead and start into the conditions of participation for nursing. And then it goes to the nursing care plan, common deficiency. Well, let's go ahead and start with the first tag number. That's 385. I include the tag number in the upper right-hand corner. So when you're trying to find this, that's the best place to go look. You must have a CNO or DNO that must be an RN. Now, this one is new. It talks about nurse staffing. You have to provide 24-hour nursing care, supervisor furnished by an RN. There also made a few changes regarding the nursing care plan. 397 is that you must have an RN to assign nursing care. Speaking of agency nurses, I include, and I want to switch over now to medications. This was a major component of the nursing section. So we're covering a vast section in here. Safe opioid use, compounding, injection practices, because again, nurses are the ones doing this. You have to have approved policy and procedures on medication. The basic safe practice talks about 5 rights of administration. We all learned this. This was Nursing 101. I talked about the blue box. This is the blue box. It's just information from CMS for us as providers. They also talked some other issues in this area. So for the eligible medications, your policy and procedures have to address when is the first dose and when can the nursing staff use judgment on the next dose. 3 timeframes. Again, thank you, ISMP. They came up with these 3 timeframes. I wish that had been around 20 or so years ago. Would have saved me a lot of angst. Now, they talk about documentation in the medical records section. And of course, those IV push medication guidelines. They talk about labeling, and this is also in the ISMP. Compounding, again, when we're combining these medication, what they're looking for, is it outdated? What is it on there as far as outdated after its expiration or beyond use date? Moving on to number 406. Drugs and biologicals have to be prepared on the order either by the physician on a right away, or you can also use order sets. Standing orders. Nurses, others who are authorized, can administer medications according to pre-printed electronic standing orders. Verbal orders, they talk about that. If you are using them, they must be only used infrequently. It has to be because of a patient's care or safety issue. It also talks about who can accept a verbal order. Blood transfusions, IV medications, they must be administered according to state law and your policy and procedures your medical staff has established. Those who are administering medication must understand the importance and type of monitoring that is required for each medication. Post-op opioids, we have to be extremely vigilant, especially post-op, because they already have sedation and then all of the risk factors involved in patients receiving opioids. Blood transfusion. As I mentioned, they did talk about adding in recommendations from the patient safety movement, and patients who are on IV opioids and those who are especially on supplemental oxygen need to have end-tidal CO2. So nursing took up quite a bit of our first part of this program. Well, now let's switch over to pharmaceutical services. Just a brief recap. This includes antibiotic stewardship program. Now, they also have some for their smaller hospital and critical access hospitals. All right, let's move over to pharmacy hospital conditions of participation. So overall, 489 is where it starts with pharmacy. It must meet the needs of the patient. You must have services that meet the needs of the patient. Your storage, the medical staff and policy and procedure, medical staff is responsible to come up with those that reduce those or minimize the errors. And again, they can delegate that to pharmacy. There's multiple policy and procedures that are required. So as far as pharmacy management, they have to make sure it's safe and appropriate for procurement of medications. Your principles include, of course, adhering to state laws. Effective December 2019, if you are handling drugs identified as hazardous, potentially hazardous through NIOSH, but as far as those drugs, NIOSH looked at 180 drugs, high alert medicines. This is a biggie. That's look-alike, sound-alike meds with those very narrow therapeutic ranges. Your QAPI and your errors, they must be integrated hospital-wide. Flag any new types of mistakes. They talk about weight-based dosing in the pharmacy conditions of participation. This is just an example, acetaminophen and ibuprofen dosing charts for children, infants, based upon their age and their weight. Back to the conditions. 492, you must have a pharmacy director, registered pharmacist, or a drug storage under competent supervision. The requirements of your pharmacy, the qualifications of your pharmacist, over to the pharmacy staff. As with anything, you have to keep accurate records within your pharmacy. Now, this isn't outside of the medical record. Delivery of services was a little bit different, updated in 2020. The interpretive guidelines also specifically mention other resources, ISMP, ASHP, USP, American College of Pharmacy, and American Pharmacists Association. Safe dispensing includes dose limits, special labeling, all medication orders. There's a first dose rule. Additional pharmacy, monitoring the effects of medications. All compounded pharmacy medications. This is also in pharmacy, so make sure you have access to their quality assurance data. Get it and review it and document that you did so. The locked storage, your drugs and biologicals must be kept safe and secure. Schedule 2 through 5 must always be locked in a secure area. What do you do with those drugs that are mislabeled or outdated? What do you do with that? Drug is outdated after its beyond use date, and it can be reached before its expiration. The beyond use is based on what the manufacturer's information gives you. What about errors, a reaction, or incompatibility? Adverse drug reaction is the unexpected, unintended, or undesirable excessive response to a drug. And then we have our incompatibilities, when the drugs interfere with each other. You have to have policy and procedures on reporting errors and events and incompatibilities, over to abuses and losses. And then, yes, we're almost finished here. We've got a formulary. That system must be established by the medical staff. FDA has a website on shortages. They have a shortage program that is available, and it has a list of those drugs to be discontinued. So I'm going to wait to see if we have any questions. I'll wait about 5 to 10 seconds, see if anything comes across. I don't see anything right now. So I'm going to go ahead and conclude. Thank you, everyone, again, for attending. Again, reach out to CMS if you have additional questions. Get it right from the horse's mouth. Print it off and keep it. That's your best avenue. So thank you very much for attending, and stay well, everyone.